So thanks very much for the invitation. Actually, as I was starting, I just got a phone call from an anxious couple going to Reunion and Mauritius and who wanted advice. So I'll bring them into the talk later, but not personally. So thanks very much, Jeremy. Um, and I think at this stage, I really want to acknowledge all the people who've contributed to the many queries, inquiries, and support that come through the NICD hotline. There you see the number. So thank you to the Outbreak Response Unit. Thank you to our provincial EPs, some of whom I see on the screen. I see our wonderful Janine there, who's always on call for seal rabies, and the many people who run the specialized units here, and the ID people who help on the ground. So without further ado, let's move on to the cases. So the first case is in fact from one of our ID physicians. I'm sure you will recognize this disease. This was a man who presented to one of the regional hospitals, was transferred to Charlotte Makeke. That's one of his contacts. He had extensive disease. In fact, had been seen at a general practitioner, I think at a clinic, and then be referred up, but there was quite a delay. And I think you can see the lesions that are very suggestive of. You can shout out, you can put it in the chat. I don't think it's a very difficult one. Anybody, Jeremy will be the adjudicator of, since I can't see the chat and I'm not going
No
to move
problem.
my screen.
I'll
Yeah,
have a look at the chat and I will shout as they come through.
yeah.
We've got all coming through. There's leprosy is the first one, mpox, scabies, and a bunch more mpoxes and one more leprosy.
Okay. So this is mpox. It was confirmed in a private laboratory and then referred to us. The patient has extensive disease and he was a newly diagnosed HIV patient who was not on antiretrovirals. He also had a number of contacts, and this was in fact confirmed as mpox clade 1B. We've had 8 cases to date, 1 in Northwest Province, 7 in the Greater Gauteng area, and not all have traveled. In fact, there is local circulation now, although the initial cases, there was a history of travel to East Africa. So the outbreak is ongoing. The cases have spread within the region from the DRC, with most cases in Uganda, in Burundi, and then some other cases in other countries in the area. So as you know, last year it was declared a public health emergency of international concern by WHO and a continental emergency by Africa CDC. And on Thursday, we're having our next meeting of the Africa CDC, and early in June, we will have the next meeting of the WHO to decide whether it should continue to be declared a public health emergency. I think it probably will. There's ongoing transmission, but a lot has happened. So there's extensive testing. There's a much better network of testing in the affected countries. We have a very good one here, both in private and, of course, at the NICD. And just to remember that the NICD will test for free if patients are not prepared to pay and they go to a private facility. We did have recently a patient who did go to a private facility and then kind of disappeared when the issue of payment came about, but we will test them here for free. So these are clade 1B. I'm pretty sure that clade 2B is still circulating, mostly MSM, severe disease, as we see here again, clade 1B, clade 2. So tecovirimat supply is still available. You just have to do a section 21, give us the reference number, and then it will be facilitated through a network. Not always easy. So if you do have a suspected case, please phone the NICD hotline. We have an mpox, a very active mpox clinical group made up of some wonderful dermatologists, mainly in KZN, and great thank you to them, and a local team. And testing can be done as mentioned. This patient did go on to tecovirimat. He had the criteria, HIV, extensive lesions. Recent studies have not really supported tecovirimat role in improving outcomes, but it's what we've got, it's what we can use, and we will use it. So let's do the next case. This was a more recent case. This was from Northwest Province. She worked in a healthcare setting, but not patient-facing. She presented with very limited number of lesions, and she did have what you could call a red eye. So although the lesions were not extensive, her last test was for HIV was in January. It was negative. It needs to be repeated. She did have one of the complications that has been seen with mpox, and that's eye involvement. You see the red eye. They can get a conjunctivitis. They can get a keratitis, and they can also get what they call a preseptal cellulitis. So it's very important that these patients have an ophthalmological consultation. There was a delay, and there was quite a lot of delays along the line, managing her, particularly with her eye problem. So the ophthalmologist did see her, did stain it up, and that's what you're seeing there. Quite an extensive keratitis. She used a cyclovir on the patient. I think we didn't link up, and I think there were a couple of gaps in management. And it did get better. And you can see the outcome on the right. The tecovirimat was started. So in fact, there's quite a lot of improvement in her sight. But there's obviously still some residual keratitis. She's now on tecovirimat, and we are waiting for further follow-up. She's probably about 10 days into the treatment, maybe a bit longer, and we'll have to see if there's any residual problems. So even though there were a very limited number of lesions, I think they were sort of about 10, and she was otherwise actually pretty well, she still had one of the complications, which is quite concerning. There's very little experience. I know the UK people have had some experience with ophthalmological involvement. Tomorrow there's a WHO Afro webinar at 1 o'clock. Anybody can join. Just send me an email or message and I'll send you the link, where we're going to talk about supportive treatment for mpox. I think there's not a lot of work being done. There's not a lot of well-controlled studies, but we do know that improving nutrition, particularly in people, particularly in children living in the DRC who have mpox, really makes a big difference, whereas the tecovirimat may not. So let's move on. So we have very devoted ID specialists who sometimes share their cases with us, and this is one of them. She visited the wonderful Kruger National Park, and it wasn't the big five, it was the little five, not that one on the picture. She was staying at Satara Camp, which is, if you see Open Gate, it's just lateral to that, about 50 k's from the gate. It's a very good game area, and I think if you've been to the Kruger Park, you will notice a lot of bats. So they have these bat houses, but quite a lot of the bats come into the chalets, mostly in search of food and nesting. So I'm not quite sure what the circumstances were. There was a bat in the chalet, and I'm not sure what the encounter with the bat exactly was, but when people see bats, they try and get it out. But anyway, she woke up with that lesion on the ankle, and mostly you see very little with bat encounters. They've got very sharp teeth, so it's not an obvious lesion, but you can see two very obvious bite marks. So it was some days later when she arrived back in Johannesburg, and we decided we would give rabies immune globulin and vaccine. So I had a discussion now with Vanda Markata, who's the big bat lady. She's really wonderful. She can make you very excited about bats. So thank you, Vanda. So I got a rundown on bats and rabies. We've had cases, very few though, of Duvenhager virus in bats. So the bat associated with Duvenhager virus is very different to the one that's generally in the Kruger National Park, and I'll show you a picture in the next slide. So this is an insectivorous bat. It's called Nycteris sabaca, and it's the slit-eyed Egyptian slit-eyed bat, quite easily recognizable. You can see those slit eyes. They eat a variety of insects, and there have been a couple of cases in Africa of rabies-related virus, Duvenhager virus, associated with this bat. So the very first patient in whom it was described in South Africa was Duvenhager, and it was in an area quite close to Bella Bella, on a farm in Northwest Province. So the patient here was sitting at Sun City and also in Northwest, outside his chalet, and a bat came down. There were lots of high-flying bats. This one came down and scratched the area below his eye. He went to the first aiders. They said, oh, it's very small. We don't have to do anything. Nothing was done, a little bit of cleanup. And 6 weeks later, he developed a progressive encephalitis. He died, and we confirmed Duvenhager virus. The one in Kenya, I think, was a doctor who was in a game park and went to wash up, and a bat came down and bit her, and she also developed Duvenhager. Not common, but really concerning. So if you have an encounter with a bat, you are unlucky if it's a Nick the Baker, as I call him. Mostly in the Kruger, it's mops, and there's 2 different species, Mops condylurus, and this was a visitor from Germany who encountered one of these when he walked into the bat on his very first day in the Kruger Park. I think it was startled. It flew at his neck, and he didn't see any wounds. And the doctor and the cruiser said, well, don't really worry. Can't see a wound. Well, often you don't because it's so small. But when he went back to Germany, they said, Africa, bat, oh my goodness, we better, you might get rabies. And of course, he started to feel very unwell, contacted guest relations, and we got the call. But in fact, that is Mops condylurus. There are lots of them in the Kruger, and they've not been associated with rabies. But you don't always know what it is. So I think it's better to address these with post-exposure if you're not sure. So there have been, I think there was one MOPS that had antibodies to rabies, but nothing else, not active infection. And the group in Pretoria, Vanda's group, have described a new lyssavirus, very similar to European lyssavirus, in a little brown bat called a Lyphotis. Well, I wouldn't know one if I saw one, but thank you, Vanda, for all that information. There are lots of them at the moment in Gauteng. They are coming into the houses looking for food and shelter. They are not rabies risks. Just leave them alone. If you go after them and you try and attack them or take them out, they're going to bite you, and then you're not going to know where you are. But really, that's not a big issue. I think what we are still having an outbreak of is rabies in seals, and Janine has been very involved from the Western Cape in following up all the cases. I think it's a well-established outbreak at the moment. When it occurred initially it was diagnosed in May, but in fact had started in 2022 and was initially misdiagnosed as domoic acid. A number of people were bitten by what were obviously rabid bats. You only have to go to the YouTubes to see these mad bats chasing them out of the water and having profound neurological signs. So this is the first outbreak in Cape fur seals. Cape fur seals are very common. They extend from the bottom of Angola right up the coast past Plettenberg Bay. We're seeing quite a few incidents now in Plettenberg Bay, Mossel Bay. And yeah, I think, we're not quite sure what to do with them. So this is one of the victims. This is from Mossel Bay. This was clearly a rabid seal. He had multiple bites. He did get post-exposure prophylaxis. He did have debridement, and I'm not quite sure how they managed to infiltrate each and every one of those wounds with rabies immune globulin. I think they did have to dilute it, and today he's fine. So we've had no human cases to date, even those who didn't get post-exposure prophylaxis, because we didn't know we were dealing with rabies pre-2024. That's how it is. We know what we're dealing with now, and we need to do some research, and we need to be very active. And I think that's all happening. So there's been a lot of molecular typing of the seal isolates now, and comparing them to what's happening in South Africa and Namibia, and they are most similar to jackal and bat-eared fox rabies in the Northern Cape. So if you see a seal colony, they're land breeding, and they live on land for quite some time. There are thousands and thousands and thousands of seals, and the jackals and bat-eared foxes go into those colonies after the pups. And obviously there was a rabbit jackal and a bat-eared fox. Now we're probably seeing seal to seal rabies. Not really sure what to do with the seals. They are doing a vaccination research program on captive seals in, I think, in Ushaka in KZN, the habituated seals around Hart Bay and Cork Bay, to try and see what the immune response is. But it's really about managing the victims. So it's about vaccinating dogs that go on the beach and making sure that they're leashed. The first victims was in fact a dog walking on the beach. There are very active, I call them One Health surveillance and response groups. There's a WhatsApp, and every day there's some sort of seal that's pictured there, and there's a response to them to view them and to decide whether they need to be euthanized and then tested. I think it's important to spread the message. We have a lot of people going seal diving, and they sign these, indemnities, but I don't think they always know what they're getting themselves into. I think if you are a seal diver, if you are a researcher on seals, if you're a fisherman, if you are having interactions with seals, you should have pre-exposure prophylaxis. And I think the Western Cape have been particularly good at following up all encounters to assess the risks and making sure that those who are not pre-vaccinated but do have a risk receive the correct post-exposure prophylaxis with both reg and vaccine. I think they've done a brilliant job. So people embarking on Ironman, the Iron Man, it's always the man, I don't know, challenges. We've had some very good interaction with them, and I think it's through the Western Cape. And a lot of them were advised about the risk and were told to get pre-vaccinated. And then we've done quite a lot of talks for open sea swimmers to tell them about pre-exposure prophylaxis. So just to remind you about rabies. Now, there are these complicated category 1, category 2, category 3. And we recently had a disaster when some wounds in a child were misclassified as category 1. I mean, a child developed rabies, is now still alive, but is a neurological vegetable, to be honest. It's terrible, and was categorized as category 1. I don't know, maybe got some vaccine. But if you see the wounds, the healed wounds, they're clearly category 3 from a dog that was unwell. So I think the important message I just want to give you is any break in the skin, even a drop of blood from an animal that is potentially rabid, so it's unusually aggressive, or it's a wild animal, it's tame, it's unsteady, it's drooling, it's hypersalivating, it's making strange sounds, or it's died, or it's run away and it looked unwell and you don't know, that is a rabies risk. You need to clean the wounds, and there's a very clear guide, lavage with soap and water, if that's all you've got, and communities can do that, 70% alcohol, iodine, start the vaccination, 4 doses, and give immunoglobulin into and around the wound. That's it. You don't have to remember all these categories. And all of those at the bottom are category 3 from animals that were behaving strangely unwell and required reg plus vaccine. Just to point out, we have 2 vaccines now. Virarab is available in the private sector. I think there's been a shortage. It should be okay quite soon. But Chirorab got the tender, and that's what's available in the public sector. Chirorab is 1 ml, Virarab is 0.5 ml, and they're equivalent. It's one dose. All right. Now the rig, we've got H rig, we've got equine rig, most of it's equine rig. You don't have to give the maximum amount. You only give what can be infiltrated thoroughly into the wound site. Many EDs have got old guidelines. We don't need it all. A small wound like that finger wound, you might need 1 amp or 2 amps. You don't give, like the old guidelines, what you can into the wound and the rest into the muscle. That rest into the muscle doesn't work. Only use what you can put into the wound. There are delays. If it's likely to be a rabies exposure and you don't have rig, for goodness sake, do whatever you can to get it. It protects the patient in those first 8 to 10 days or whatever while the vaccine is working. It is what makes the difference. So this year we've had 3 confirmed cases, 1 probable case. It's the patient who's still sort of alive, got some post-exposure but did not get rig. And it's a serological diagnosis on the CSF. Just remember, mostly you can't use serology to diagnose rabies because patients don't survive to make that antibody response. This child did, and there was an IgM in the CSF. The IgM in the CSF is always due to rabies. It can't be due to rig or vaccine because it does not cross into the CSF unless there's meningitis, either way. But that's generally not the case. So if we look at the failures, the 2 didn't go to the clinic. The 1 did go to the clinic. Rig was prescribed, but the patient didn't go to the hospital. And there's always that breakdown. All facial wounds from a potentially rabid animal must be referred to the hospital. Those are the high-risk ones. Those are the rigs that are difficult to give and may need some sort of local anesthetic, not local anesthetic, a general sedation to allow the process to be done. Giving rig into the eyelid, if that's where the bite is, or the lip, or the scalp, or the earlobe on a child is not easy and needs to be done by people who are familiar with it. Remember, equine is a product with potential allergic reactions. You need to watch the patient. We recently had a case where they didn't have enough equine. So you can't give some and then you bring them back the next day and give them more equine because there may be a sensitizing process with the first one. Anyway, we gave H-Rig to kind of mop it up. Okay, so these are all category 3 exposures. The one in the middle, the stray cat, was the most recent one. You can see it's broken the skin. You can see all the others have broken the skin. They are all category 3, and all the animals were either vicious or unknown or kind of typical, the shy animal in the Karoo that came up to the farmhouse. That doesn't normally happen. The child on the bottom right was a facial wounds from what seemed to be a potentially rabid animal, did not get rig, and that's taken when the child presented with signs and symptoms of rabies. Really tragic. Okay, so pre-exposure, just to remind you, and you can go to the guidelines, we should include all occupations now, all travelers, all recreational risks, and anybody living in an area where there's rabies, but they probably can't access post-exposure, like a farm where, they're not close to anywhere. What pre-exposure does, it obviates the need for rig post-exposure. You can use 2-site IDs on days 0 and day 7. It's dose saving, it's cost saving, and it's a very controlled setting. So if you've got open sea swimmers, you can line them up and you can do it. Okay, this was a researcher who went on a research ship to Marion Island. They were doing some dissection, was a practical, they called it a university at sea or something, and did a necropsy on a seal and cut herself with some skull bones and a scalpel that had been almost in the brain, and the ship had to turn around. because we knew nothing about that seal. She wasn't pre-vaccinated. It was an absolute mission to do that, and she got PEP, thanks to the ED in Port Elizabeth. And in fact, that seal, even though it was frozen, had rabies in it. So we did the right thing, but she should have been pre-vaccinated. Let's move on to something else. So this is a young
Sorry.
man of 15.
May I just ask, sorry, one of the questions that came on the chat's a good one, asking about whether we think this is going to be long-term endemic in Cape fur seals.
Yeah. So we wish we knew. We don't know the extent. I'm sure many of the seals just die at sea, and we don't really know how they infect each other, and we can't do very much about it. So I think it is going to be long-term.
Okay.
They may pass it on to other mammals. They can't pass it on to sharks. Remember, they're not mammals. They are fish. So if they're eaten by a shark, that's not going to make any difference. But it is a concern, and it probably is going to go on. We just don't know the answer.
Okay. And then, you mentioned, people like Iman and that. So, I mean, I had a question last month that was asked me by a in Somerset West who was asking whether he should get, and he says he's often out there by the seals. My suggestion was, yes, get rabies pre-exposure, get the vaccine at least, and you don't have to worry about the rig. Do you agree with that?
Yeah, absolutely. Yeah, at your expense. Remember, post-exposure it's free, but just line it. Take a friend with, and you can share the vial. If it's Cairo Rab, it's a whole mill. You can do quite a few friends. Very, very nice.
Cool.
Okay, can I go on? So this is a young man of 16. He lives in Mauritius, and he's from a family that befriended a group of swimmers who went to Mauritius for some championships. So he had fever, he had a rash, he had some myalgia, he had some arthralgia. He wasn't that sick because the day after this picture, he had to go to school to write his exams, and he did. So what do you think this is? Anybody?
I'll read the chat as it comes. We've got 2 takers of chikungunya so far.
Yeah. Okay.
I'm sure
Anything
others
else?
are typing. And the third one agrees with chikungunya.
Okay. Anything else? Differential? Must have a differential, Okay, I think dengue would be a differential because both circulate in Mauritius, and in fact, both are present currently. So chikungunya is an alpha virus transmitted by Aedes mosquitoes. We've got a number of different species in various parts of the world. It's usually a self-limiting illness. A couple of cases go on to chronic arthritis, but the key feature are the ones I've mentioned: fever, myalgia. The rash is exactly as you saw it. Can be on the palms. You often get a very red mouth. You can sometimes get a bit of conjunctivitis, but arthritis, which is where the name comes from. It's a Makonda name saying that which bends or something like that. Is a major clinical sign and symptom. Case fatality rate is very low, more severe in newborns. It's not transmitted by pregnant mothers to the fetus, but they can get infected around the delivery stage. Elderly and those with comorbidities, like those who are diabetic. Now, there was a very good webinar with WHO, with the presentation from representatives from Mauritius and Reunion. And in fact, they are doing PCR as their key diagnostic test, but they also have acute and convalescent serology as part of their diagnostic armamentarium. So they are doing a lot of testing. Treatment is symptomatic. Some are really quite chronic and quite debilitating. So, it's not the greatest disease. Now, you often find other parts of the world, but at the moment, I would have made the Indian Ocean Islands a little darker, is where the current outbreaks are. So that's the mosquito. You might find them even in your garden in Johannesburg, in your strelitzias. It's Albopictus and Egypti. And these mosquitoes are also responsible for dengue, Zika viruses, and a number of other viruses. So you may have co-circulation of these other diseases. For the Indian Ocean islands, the most important would be chikungunya at the moment, but also dengue, and you have this overlapping clinical picture. So I found this slide from 2006, when there was an outbreak in Mauritius, Comores, Seychelles, and Réunion. And in fact, we did see quite a number of imported cases, mainly coming to KZN, but no local outbreak. So we have had chikungunya in South Africa. There was an outbreak some years ago in Maika, quite close to Phalaborwa. Cycle is slightly different. The reservoirs are non-human primates, but in the outbreaks, it's mosquito transmitted from infected people to other non-infected people during feeding of the mosquito. So it's person to person with the help of a mosquito. And it's really quite you get a lot of cases when you get cases. So these slides, and sorry for the print that's not wonderful, were from the presentation, the WHO, and directly from a Réunion. They spoke about the outbreak in 2005, 2006. And there were a huge number of cases. Now, a lot of those people will be immune now and may not get infected now, but the immunity may not be complete. So you may, and they're not sure about this, get second infections. So for quite some time, it was probably due to immunity. There was no local transmission and they didn't see cases. They had very few imported ones. But at the end of August 2024, which would have been winter, they do quite good surveillance on Reunion and particularly in Mauritius. They had some PCR positive cases, and they found they hadn't traveled, and they were local. They had limited circulation for 2 months, but after that they started to see expansion to the south. Oh, sorry, I keep getting this wrong. Okay, so those are the affected areas in Réunion. They do really very nice outbreak curves. A number of cases appear to be coming back. They count the number of consultations for this acute febrile illness, and then they've obviously done, not all, but quite a lot of confirmations. But the trend seems to be downwards. So these are the hospitalized cases. 3 distinct populations, so pediatric cases for pain management, pregnant women for fever management, and to monitor transmission. They do monitoring of the maternal-fetal transmission, and then older patients, and particularly those who are diabetic or have got underlying cardiac problems. They've had a few mortalities, and it's really in that older group. Now, Mauritius, they noticed the first cases and they reported them, and I think they did a really good job with surveillance and letting the rest of the world know. It's a very popular tourist destination, and I think perhaps it puts people off a little bit, but only a little bit. It's a lovely place to go. They started to see cases in late March, and in fact, the cases are still continuing to increase. So unlike Reunion, where I think they're going down, I think we're still having an outbreak here. It's not everywhere, but it's difficult to say. That's what was reported up to May the 5th. And in fact, the phone call I had as we were starting, the husband and wife going to Mauritius for a holiday, don't actually remember where they were going on the island, and they wanted to know what they could do. So they've got very good documentation, and really they have very good public health there. So there's the chikungunya, and there's dengue. So I think if you have a patient who's returning from the area, you need to look for both. Clinically, they do overlap. The rash of dengue is a little different, as you can see. Usually less conjunctivitis, less arthritis, but certainly an overlap in symptoms, usually much lower platelets and a lymphopenia. But it's important to test for both. Dengue needs to be more actively managed in case there are complications. So what are they doing? What about prevention? Well, I think they are quite strict about breeding sites And these mosquitoes can breed in just pots of water around your house, in the watering can, in the tires. And if you do have water in those areas, they will fine you, and they will also do some fogging and spraying. And that young man was waiting for the spraying team to arrive in their households. So there are two new vaccines, Vicuña and Ixchiq. There they are. They may be used for selected travelers, expats living on the island or going to live there, and maybe for some at-risk residents. Neither are registered here. Ixchiq has made people aware of some safety concerns in patients in travelers or people receiving the vaccine over 60 years. There have been some cardiac and neurological adverse events, and they're reported as serious ones. So I think much more important to take mosquito prevention. Remember, they're daytime biting, late afternoon, and it's about using tabard lotion to protect yourselves. There are notifiable diseases, chikungunya and dengue, and it's the labs that notify. So NICD does a full range of arboviruses. Contact us if you need some help. But a number of the other laboratories will also test, particularly for dengue. But it's the labs, I think, duty to notify, and they do that monthly. We've had 2 cases this year in South Africa. One was from, I think, the Ocean Islands, and one was from somewhere else. But, you know, we may see some more. Okay, next case. What do you think? So here are 2 pictures. This was a quite miserable child, young infant, who presented to one of my colleagues who sent these pictures. So let's hear your diagnoses. Now look very, very carefully. The child was very unhappy, appeared unwell. Not a great fever, I might say, just low grade, but was not a happy child. You can see that face, miserable. So what do you think? What's your diagnosis?
Neresa's saying myiasis, Judy's saying spider bites. Tom's asking where were they? The family, I guess.
Pretoria.
Oh, Pretoria. Okay, cool.
Yeah.
Another vote for myiasis. She really does look miserable, Lucille.
She's very miserable. So she was admitted, and they decided to give her IV antibiotics for what they thought could be staph or streptococcus. But if you look at that, and you've seen enough of these, you will see what looks like, especially on the picture on the left, there and there, this little black sort of aperture, I can call it, but it's black. So I said to them, all right, give your IV augmentin, admit the child, and go and buy some Vaseline, petroleum jelly, and apply to some of them. You know, we'll do this test. And out popped larvae of that was compatible with myiasis. There we go. And so this is myiasis. Really very nice demonstration. Probably not secondary infected. I think it's an inflammatory response to the presence of the larva. And what's important is those larvae will eventually pop out, but you'd like them to pop out sooner rather than later. So, you know, the petroleum jelly is really quite important, very easy and very cheap. So once they're out, that inflammation goes down. Don't go digging around. You're just going to make it worse. And whether you use antibiotics or not is your choice. It was I think I didn't see the child, but I saw the pictures, and we've had a number of these before. So this is myiasis, and these are Cordylobia anthropophaga. These are tumbu, mango, putsy flies, whatever you want to call them. They lay their eggs on clothes that are put out to dry, and then just put onto the person without going through an ironing process. And then the eggs hatch and the larvae burrow, and they cause this local inflammation. So, you know, we've had a lot of rain. I think there's quite a lot of these flies around. We certainly see them on the Highveld. We've had quite a number in Johannesburg. I remember Florida had an outbreak, and certainly Pretoria. So I know areas like Durban have quite a lot, but they can occur everywhere. So just keep your eye out, and a little bit of petroleum jelly does the thing. I don't know where that came from. Okay, so how much time have we got? I think we're good. So we've had a diphtheria outbreak. It is ongoing. Thank you to Jocelyn Moyes and the CRDM team and all the people who are involved in the diphtheria response. It is we have a wonderful diphtheria hotline made up of a number of pediatric and adult ID people, pharmacists, the CRDM team, the NICD team. If you want to access any help, phone the NICD hotline, and then there will be this review of your case. They really are not easy. So to date, we've had 50 symptomatic cases. There you see the age range, a lot of adults. So these would be adults who never received their booster doses. Most people don't receive their ongoing booster doses. Quite a lot of asymptomatic carriers. These are contacts of cases. So these, so it's a public health issue. And then you can see it's ongoing. I think it's too early to say whether it's downward or upward, but really a number of provinces affected, which has made it quite difficult to manage some of the treatment issues. So these are pictures of cases. Thank you to the doctors who submitted these and the patients. A picture tells a story, but I can tell you it's not easy. And getting these pictures, mostly you just see red and back of the uvula, can't see much else, are really important to try and make the decision. But it's a high index of suspicion: sore throat, adherent membrane. The classical membrane of diphtheria doesn't come off easily. It's gray. If it does come off, it often bleeds. But there's a differential diagnosis, including Streptococcus pyogenes. And one of our recent cases was, in fact, acute, rapidly progressive strep pyogenes, probably toxic shock syndrome in a young 10-year-old. It was a little too quick for diphtheria. Patient developed multi-organ failure and unfortunately demised. We weren't sure what the diagnosis was. There was also a rash that I think was suggestive of maybe it's something else. We did give DAT, did get intensive care, even got ECMO, but didn't survive. So fever, sore throat, membranes, send us pictures. The finding of the bull neck is quite helpful. But what's really important is to have a high index of suspicion and to manage on that suspicion. So phone the hotline. We will support you. I don't think we have all the answers, but there's a collective decision about management. And management is number one, is making sure that the airway is patent. It's number one. And then access to diphtheria antitoxin as soon as possible. You want to give it before the toxin binds to the receptor sites on the heart or the kidney, or it's once it's bound, the inevitable will happen after several days. So DAT is available in some hospitals. It's available in some private sector hospitals, but very few. There is a supply with the pharmaceutical services, and I have to commend the ones in the Western Cape, Helen and co, who've been absolutely marvelous. We did have a donation from the WHO, but now it's needing to be purchased, and there are specific guidelines. So you need to get consent, Section 21, which can be a little bit of a mission. You need to work out how much to give, and there is a guide depending on severity of illness and how long the person has been ill. If it's more than 4 days, it has very limited effect. As the days increase, we give more, but there is a guide. It's given intravenously. We don't do sensitivity or allergy testing, and you have to give all of it at the same time. You can't give some today and some tomorrow if you don't have enough, because it will increase the risk of hypersensitivity. So there is the guide. If you can't remember all of this, we do have something on our NICD website, but that will prevent or reduce the risk of the cardiac and renal complications so as soon as possible. But the most important is to secure the airway. You know, that's not going to help you if you can't breathe. Start azithromycin and initiate the public health response. Notify the case. Be very careful of the airway. You know, when I was in ICU, I just remember trying to intubate these patients. It was impossible. You could get a size 3 tube through sometimes. So you need an ENT available, or somebody who is skilled at doing a tracheostomy. That might be needed to be done as an emergency procedure. There are some warning signs that things are going to obstruct. Noisy breathing, stridor or stertor, drooling, limited mouth opening, plummy voice or hoarseness, can't lie flat, a bull neck. Really, you need to move quickly. That patient is going to obstruct. Do not use oxygen saturation monitoring to decide whether there is a problem. The SATs will go down when it's very, very late, too late. So watch for these and get the help of an anaesthetist or an ENT person to evaluate the patient, but also to help with the airway. It is the most important. The testing is done at the NICD. The testing is started in a number of the NHLS and private laboratories, and we're trying to take the PCR for toxin testing out to other areas like the Western Cape. But I think one of the private labs is now also doing PCR for diagnosis and for toxin testing, but we can ask about that. Any other questions on that, Jeremy? I think we're getting to the end.
Nothing in the chat, yeah.
Okay. So sorry to revisit some of the diseases, but I think it's important to remind you we're still in malaria season. It's overlapping with influenza season. We're seeing a lot of influenza, still some COVID, and also some RSV. People are traveling, and I think this is the most important slide in this collection. Any patient with fever, flu-like illness, progressive acute illness, you have to ask about travel, ask where they stay. And the first test you do is not a COVID test or an influenza test. It's a malaria test, either a rapid test or a slide. Do it properly. Don't read those malaria tests in 2 minutes. They'll all be negative. Read them at 20 minutes. And if it's a lab, get the results and repeat it if it's negative. So yesterday I had a patient from a GP who'd been to the Timbavati. He had sweating and fever and myalgia, and she was very good. She's well trained. She did a malaria test. It was negative. At the same time, she did an influenza swab, and it was influenza A. But you know, I think you have to do the right things. Do not miss malaria. That's why patients die. Key messages. Think malaria, okay? And I've given you that message. Be careful in pregnant women with fever. Same. Have you traveled? You live in a malaria area. It's not a UTI as you would normally think. You know, think malaria if the setting is correct. Be careful of jaundice, any change in the mental state, increase in respiratory rate. It's not fever, it's a metabolic acidosis. These are the subtle ones. You know, the severe malarias who flat out, who pop, who whatever, they're easy to diagnose. But it's the ones that have got a bit of jaundice, bit of increase in respiratory rate, you know, they're going to move very quickly. And if it's day 4 of illness, you need to move quickly. On day 5, day 4, day 5, they're going to crash quickly. So be careful. Make sure you've got Garson or artesunate in your EDs. And if you do diagnose malaria in a patient who's got any sign of severe malaria, they need to get IV artesunate. And the first dose must be given before they go to the ward. And it must be available in the ED, not under lock and key, dependent on the pharmacist or the matron coming to open it. There are long delays in diagnosis in an ED and the patient being seen in the ward, sometimes 28 hours, and the patients die. Every patient needs a full course of Coartem, even if they've had artesunate, otherwise they'll come back. Remind, and this is, I think, being forgotten, coartem must be with fatty food to ensure good absorption. And if the patient is over 80 kilograms, just consider extending that same coartem dose to 5 days instead of 3. For holidays, it's the question that we often asked. Obviously, it's good personal prevention of mosquitoes. And at this time of the year, that's probably what you mostly need. None of the things on the left apply. You could drink as much gin as you want. It's got nothing in it. You'll have to have lots of tonic water. And those nonsense homeopathic things, even with artemisinins, don't work. And the man with the hood is not going to work for mosquitoes that transmit malaria because he's wearing it during the day. So there is a pediatric chemoprophylactic preparation now. It's called hitovenol. It's available over the counter. And so we do again have a chemoprophylaxis for children, hitovenol. And just remember, at this time of the year, we do have some cases of meningococcal disease. The meningitis is easy. You know, they have meningism, stiff neck, vomiting, whatever. It's the meningococcemia that is quite hard. And the usual is a child, and it's often a young person or a child or a student. They come to the health facility and they've got fever, and they come back later, 2 hours, and they're vomiting. 3 hours later, they're lethargic, and then they've got this rapidly progressive rash and multi-system problem, often a low white cell count, and very little on the CSF. So just think about meningococcal disease and acute, rapidly progressive febrile illness in patients. Meningococcemia is often missed because of paucity of signs, and ceftriaxone can be life-saving. So I think I've come to the end of my Cook's tour. So lots of old diseases, maybe with new twists and a needing for reminders. Not a lot of exotic rashes, sorry, Jeremy, but I'm sure we'll collect them by next year. Good histories, same rules apply. Where do you play, stay, travel? What's your exposures? What did you eat? What's happening in the area? Look for key dermatological signs and do some basic bloods, and you're likely to get the diagnosis. Don't believe everything the laboratory says. You must select the right tests, and if it doesn't fit with your epidemiology and clinical, you're not in the right direction. They all need to fit. The puzzles must fit. Exposures, risks, clinical picture, and laboratory must all come together. And I think I've come to the end of my tour.
Fantastic. Thank you very much, Lucille. Brilliant as always. And lots of comments, been messaged to me as well, and some on the chat as well to say very much and thank you. One question that did come through is just on the malaria prophylaxis. You did kind of mention it in passing there, but it's there's been a lot of shifts with deregistration of various medicines. So what's the kind of lay of the land at the moment with malaria prophylaxis in terms of availability of the various agents?
Okay, so for adults, I think it's quite easy. There is tovacone proguanil, Malinol, Malarone, Malitec. There's quite a lot of generics, and that's fine if you're over, if you're an adult or over 30 or 40 kilograms. If you're not pregnant, doxycycline is still available. It's also available in the public clinics, so we can give our travelers who access public clinics prophylaxis if they're going home to or traveling to areas like Mozambique. And not as well tolerated as Malinol, tovacone proguanil, but obviously more affordable. And then for children, the hitovenol, the tovacone proguanil. And then for pregnant women, you probably should go, as I always say, to Malmesbury or Margate. They can get mefloquine, section 21, and I know some travel clinics, some of you may be on. There's a funny thing happening here, never mind. That could be given, but perhaps persuade them not to go because it's not a good combination. The malaria program's actually done pretty well. The number of cases in South Africa is right down, and I think we're seeing, I don't know, somebody can correct me, 3,000 local cases in this past year. number of deaths are down, but no one should die of malaria. Excellent drugs, diagnostics. Over the border, Mozambique, I think the control, even though they have some very good programs there, run by NGOs and private-public partnerships, hasn't been as good as it was. They've had a lot of civil unrest and a few natural disasters with weather. So it hasn't been as well as good as they would like it to be. So I think that remains a concerning area. We're moving into the low risk season. I think now the most important is mosquito preventive measures. You're going across the border, add a chemoprophylactic, and I think high awareness. It's about telling your patients, if you come back and you've got a fever, you've got flu-like illness, demand a malaria test, patient power. Don't fall into the COVID influenza trap, which I think is quite easy. And the urgency. When you get to day 4, day 5, and you've got malaria, you are in big trouble.
Yeah, absolutely. And as you say, being aware that this fever typically doesn't occur immediately, that it's 2 weeks later potentially, after you've come, and that people don't link to their travel.
Yeah.
Great. Thank you so much. Again, can't thank you enough. It's really our highlight for us in the year. So thank you so much for giving your time and expertise and for refreshing everyone. Have an audience bigger than normal today, and that's entirely due to you. So thank you very much.
And thank you to Shloni, who's sitting next to me and making sure I don't mess up the slides.
Most importantly, yes. Thank you very much.
Thanks very much, Jeremy.
Cool.